Good morning. I prepare my slides in English, but as requested by Fondation, the Fondation of Academy de Medicine, I will present in French. But after we can discuss in English. Voilà, donc je vais vous parler aujourd'hui.
I'm going to talk to you today about the French position and the difficulty we encountered taking a public health decision prior registration of the dengue vaccine. It's a very complex vaccine in itself, and its protection modalities are complex. Also, the vaccine is currently being studied by the European Commission. It has not yet been registered. Third, the epidemiology overseas is geography specific, it's evolving fast, there have been recent pre-epidemic situations. And fourth, I won't talk about this too much, it's a bit theoretical, but there is potential interaction between dengue and Zika in particular. And when you have antibodies against Zika, potentially this may increase the severity of the reaction to dengue. So if you vaccinate against dengue just prior to a Zika or chikungunya epidemic, we don't really know what will happen in terms of risks. A brief reminder, the dengue vaccine is called Dengvaxia. It's the first vaccine sold by Sanofi Pasteur. It's a chimeric vaccine. The whole replication machinery comes from the attenuated yellow fever strain. There are also genes encoding for envelope and the pre-membrane replaced with those of dengue. The four serotypes are quite different. There's a 40% divergence. So it was necessary to have four different vaccines, four recombinant vaccines in the same vaccine, all rolled into one, as you can see on the lower left. It's a recombinant quadruple vaccine. All the trials were carried out, as Professor Chinas showed us, 3 injections 6 months apart. When you give 3 injections at 6 months apart, it's important to provide protection, but what if there's an epidemic, like a flu epidemic? And then there's a follow-up phase. People were followed up for all kinds of dengue. There were sub-studies per age, per risk factor, and then sub-immunological studies. Then there was a long-term follow-up over 4 or 5 years. Here you can see follow-up 2. Sanofi Pasteur has reached the follow-up 2 stage. It has results 4 years after the end of the actual vaccine test. And in the follow-up, it's mainly hospitalized patients for all the different types of dengue. As stated, this is a vaccine which reduces the very severe forms. It's very effective in the trials, be it in the Asia and the Pacific or in Latin America. Like in cycle 15, there's a reduction of 94 to 95% in severe forms, a similar reduction in hospitalization. Whatever the form of dengue, it's effective with a reduction of 56 to 60%. What makes the analysis rather complex is that when you look at the protection factors, you have age. The vaccine is more effective in people who are over the age of 9. However, in very young children, between 2 and 5, there is an increased risk of dengue in the years following vaccination. Second, the efficacy depends on the serological status. Strangely enough, you have to have been primed by the vaccine for the vaccine to be effective. It's less effective if it's a first vaccination in an uninfected person. Then it depends on the serotype. There are serotypes where it works better. Serotype 2 works less well. That's maybe due to the choice of the initial serotype. Here you can see the efficacy, which increases with age. Between the age of 2 and 4, the efficacy is low. However, as of the age of 9, the vaccine efficacy is higher. It's about 65%. If then you target this population above the age of 9, we can look at the factors linked to efficacy. At the top, 65.6% efficacy in this age group, 9 to 16. Dengue 1, dengue 3 and 4, it works well, but it works less well for dengue 2. It works very well with the severe dengue forms, and in the lower rectangle it works better in seropositive, dengue seropositive than dengue seronegative patients. There's no very reliable test for screening dengue seropositive patients. There's a cross-reaction between the arboviruses. So basing a vaccine on a serological analysis is not a good solution. In the youngest people, there's in fact an increased risk of dengue. As you can see here, you can hear the youngest people are on the left, the older people are on the right of the slide. Normally, with the vaccine, there's more dengue in the control group than in the vaccinated group. The control group is in orange, the vaccinated group in blue. Over the age of 9, you can see that the vaccine affords good protection, and the protection lasts for up to 4 years. On the left, in younger children under the age of 9, we can observe, strangely, that there is more dengue the third year in those who have been vaccinated than in the controls. This higher risk isn't very well understood. It's probably due to the fact that there are facilitating antibodies, so when they encounter another kind of virus, instead of the antibodies neutralizing the virus, they facilitate infection. But the immunological hypotheses are hotly debated. So there is a trend towards attenuation. It's a passing phenomenon, but it is disquieting. So it means that you can't do widespread vaccination in people under the age of 9. In summary, before I talk about the position in France, this is a vaccine which is a live, attenuated, recombinant one. It works a bit like attenuated dengue infection, making it more mild. We know that severe dengue occurs when you're infected for a second time, so it protects against severe dengue. It's more effective in people over the age of 9, particularly if they're already seropositive, and more with dengue 1, 3, and 4 than dengue 2. And in young children from 2 to 5, vaccination is linked to an increased risk of severe dengue after 3 years follow-up. Whence the WHO recommendations, which really followed the opinion of the SAGE group. The advice is to encourage countries to implement vaccination in geographical contexts where there is high dengue morbidity, in age groups where seroprevalence is around 70%, or at least 50%. If it's under 50%, then the efficacy will be low. In children above the age of 9, there is no higher age threshold, but the vaccine is not recommended if seroprevalence is under 50% in the age group focused for vaccination. In October 2016, and I'd like to thank Sanofi for giving me this data, the file was submitted to the health authorities of 28 countries, and most of them are endemic countries. The vaccine was already registered in 12 countries. In Asia, it's been registered in the Philippines, in Indonesia, Singapore, and Thailand. In South and Central America, it's been registered in Brazil, in Mexico, in Peru, in Guatemala, Salvador, Paraguay, Costa Rica, and Bolivia. Either it's been registered in the whole country or in just some states. In Brazil, There's a state-based health policy. In some countries, the state pays for the vaccine for the entire population. That's the case of 3 regions in the Philippines and 2 regions in Brazil. In Europe, the file has been submitted to EMEA, and questions are being asked, so we don't yet have the authorization to market. But in this pre-registration situation, the question was put to the health authorities, and the Director General for Health put the question to the Technical Vaccination Committee. Might it be timely to do a pre-registration vaccination in certain regions? Here you have the overseas regions. We basically analyzed the West Indies and Guyana and the islands of Réunion and Mayotte. This work took place between June and October. I can talk about it now because the opinion was recently made public on the 7th of October. The work consisted in analyzing the epidemiological situation in these areas to see whether there were some risk factors of severe dengue so that these areas could be targeted for vaccination, analyze whether the vaccine would be effective against a future outbreak, and look for interaction between dengue and Zika. I'm going to talk mainly about the 2 first indents here. The epidemiological situation. In the West Indies, the French West Indies, and in French Guyana, these are areas of high transmission of dengue viruses. The main vector is Aedes aegypti, which is very effective as a transmission vector. There are epidemics every 2 or 3 years. It's not really seasonal in Guyana, but it's seasonal in terms of the rainy season in the West Indies. The attack rate is about 10%. Hospitalization rate is 1% in the West Indies and 2 to 3% in Guyana. The percentage of severe forms is about 1% in the West Indies and a bit higher in Guyana. And there's a small number of deaths directly due to dengue, 12 in French West Indies and 6 in Guyana. The serotypes: you have the 4 in the West Indies, above all dengue 4, and in Guyana you have mainly dengue 2 and dengue 4. There have been few seroprevalence studies because the problem was a bit underestimated. When you look at seroprevalence studies, the latest dates from 2011 and concern blood donors. Seroprevalence is very high. 86% of people are seropositive, 90% after the age of 20. Under the age of 18, we have no data. In French Guyana, a study dates from 2005-2006 in pregnant women, 92% of pregnant women have already had dengue. What about what happens under the age of 18? If we recommend the vaccination, we need to know what pertains to other age brackets. So we looked at bordering countries. Here you have Santo Domingo. You have the age and seroprevalence. As of the age of 5, the seroprevalence is about 2006. The prevalence in the population is very low, 3% at La Réunion, and no more than 22% in Mayotte. So this is not conducive to widespread vaccination. In light of the situation, we thought, are there dengue risk factors? Instead of doing widespread vaccination, you could target certain groups of the population. Indeed, there are studies, but the methodology is a bit weak, apart from the well-known factors, which are young age. Young children have an increased risk of hospitalization, and second infection with another serotype. And there you have an odds ratio of 7 of developing severe dengue. But if you have a 3rd or a 4th or a 5th infection, it's not the same. Now, if you look for other factors, age is a risk factor and a factor of complications. Older people will have more comorbidities. Being a man, male sex, leads to more complications. Sickle cell anemia, mainly the SC forms. There are a lot of people with sickle cell anemia, 1 out of 2 or 300. and diabetes with hypertension. That also goes hand in hand, apparently, with increased severity. But these are studies which use a limited methodology. The results are heterogeneous. And I think it would be worth working together on these risk factors for dengue in adults. So in conclusion, there are two conclusions. One for Guyana and the West Indies. The High Public Health Council recognizes that these are zones of high transmission of dengue. The Public Health Council feels that there's a recommendation for vaccination, but it's not urgent prior to registration. We'll reconsider things as soon as the vaccination has been registered. There are certain comorbidities, mainly sickle cell anemia, affecting 1 out of 200 to 400 people, and perhaps diabetes, about 10% of the population, which are associated with a higher risk of severe dengue. For the time being, the benefit of vaccination is uncertain, because there are a lot of people who are still seronegative. That might increase the risk of severe dengue in these people. We don't have a reliable diagnostic test. There's a great discussion on diagnostic tests. We don't have one which makes it possible to identify people who had dengue and those who had a different kind of arbovirus. So for the time being, there's no need to ask for vaccination prior to registration. For La Réunion and Mayotte, vaccination has not been recommended for different reasons. It's because seroprevalence is low in these territories. It's difficult to identify patients at higher risk of dengue. So the recommendation is to do seroprevalence studies as soon as there's another epidemic. There will no doubt be another outbreak. And in the course of the epidemic, we could get a really good idea about seroprevalence. Take greater measures against individual and collective measures against mosquitoes. Reconsider the question in the event of a change in the epidemic pattern. So this leaves a lot of scope for questions where we could give some thought and perhaps work together in order better to understand the efficacy of the vaccine in real life, and also to see whether there is a medical and an economic impact. We need to look at interaction between dengue and other arboviruses. If we perform vaccination, we need to have long-term follow-up as to the duration of protection and safety. That is very important, of course. Efficacy in non-endemic zones, for us, that's important too. Vaccine use in specific populations, pregnant women, and so on, and then cost-effectiveness studies. Thank you for your attention.
Merci beaucoup, Dominique.
Thank you very much, Dominique. Are there any questions? Patrice Debray? I don't know whether this has been studied. We've talked about children and adults and severity. There are different subclasses, therefore subcategories. Maybe it would be worthwhile conducting a study on the different subcategories. We've been doing a lot of studies in Africa on co-infection with chikungunya, for example. Sometimes response against the first type of infection will change if there's a second infection owing to a different kind of vector. Yes, there is a subset when it comes to immune response, but there's a very weak difference. We're talking about the children and the general population. It's very interesting to look at this in the post-vaccination period. We should conduct more sophisticated immunological studies in the post-vaccination period.
Dr. Salmon, I think, first of all, I must congratulate you on a very balanced presentation on what is a very complex issue. I think some of the things that you have highlighted, and I wonder, maybe we can discuss it in the post-lunch meeting. One of the first things that needs to be done in India, and you've seen that the data even from the Francophone countries is similar. We have just sporadic studies on seroprevalence from various parts of the world, and India is the same. In my presentation, I'll just mention approximately what we've seen. So there is a need at this point of time to carry out age-specific seroprevalence studies in different parts of India. And if we can look into that together, age-specific, type-specific, in different parts, that would be the first priority before we think of a trial. Because trial will need registration, as already pointed out.
Sure, I agree. It would be very useful, and seroprevalence by age, to see after what age the seroprevalence is over 50%. Thank you.
Alors, une question, Yves Buisson et ensuite monsieur. Il faut éteindre, c'est ça, vous n'allumez pas avant de parler parce qu'autrement ça ne marche pas. Je suis un peu surpris par le
I was a bit surprised
fait que l'indication de vaccination repose
to
sur
see the indications for vaccination because they are based on over 50% seroprevalence.
Ça signifie que
Does this mean that under 50%,
suffisamment endémique, donc que les personnes ne sont pas suffisamment
it's not sufficiently endemic, there isn't high enough a risk to warrant vaccination? Or is this based on the fact that people with antibodies will respond better to the vaccination? It's the second hypothesis mainly. If the vaccine works as well in seronegatives as seropositives, you wouldn't have the threshold problem. When the person is seronegative, the vaccine is less effective. For the vaccine to be effective, the person has to be seropositive. If you have over 70% seropositivity in the group to be vaccinated, then it's really worthwhile. If, however, the seroprevalence is low, you're vaccinating half of the people for nothing. WHO therefore said that you should consider vaccination in areas. In a given country, you can have different zones. In zones where seroprevalence is above 70%, then you need to vaccinate. WHO said it's acceptable between 50 and 70% as well.
Merci, monsieur.
Thank you. What is the position of the French state on the Pacific territories? There are dengue epidemics. Do they have a fairly autonomous health policy compared with mainland France? You're talking, for example, of Tahiti. Well, they haven't called on us yet. They haven't called on the ministry yet. I'll sum things up very quickly. It took a lot of work to gather all the data, but this work needs to be done in the other French territories too. But they have their own Ministry of Health. The health authority of La Réunion, Mayotte, and the French West Indies called on the ministry to see whether they could get the vaccination prior to registration. Once the vaccine has been registered, then that's a different case. That's a different situation. We can have a complete evaluation of all people at risk of dengue in France. But prior to registration, it's a bit different. We were called on. The question was, prior to registration, might some people benefit from the vaccine? We answered the question, and it's true. For the time being, we don't have any analytical data from the other overseas areas. Thank you very much.